COPD, a common, preventable, and treatable disease characterized by persistent respiratory symptoms and airflow limitation caused by airway and divided by or alveolar abnormalities due to significant exposure to noxious particles or gases. Emphysema, damaged and enlarged alveoli causing the loss of lung elasticity. Chronic bronchitis, chronic productive cough and sputum production for 3 months throughout 2 consecutive years. Emphysema causes loss of lung tissue, recoil, and air trapping. Air trapping is very important to know. Think emphysema equals entrapped air. Chronic bronchitis causes mucus secretion and airway obstruction. Think bronchitis equals boogers. These patients have a lot of mucus. There are several factors that can contribute to the development of COPD, but the leading cause is smoking. Although some individuals may perceive smoking as a way to enhance their image or social appeal, it is important to prioritize one's health above such perceptions. Another factor that is equally dangerous and can contribute to the development of COPD is passive smoking. This occurs through the inhalation of secondhand smoke in environments, such as exposure to household chemicals, bonfires,
look what I have created!
Industrial settings, or any location where individuals are in close proximity to smokers. Attention! Alpha-1 antitrypsin deficiency is the only known way to develop COPD without any environmental exposure. It is a genetic condition in which the body lacks enough of a protective lung protein, making the lungs more vulnerable to damage. This can lead to early onset COPD or emphysema, even in individuals who have never smoked. Early detection is important for proper management and treatment. Common symptoms of COPD include fatigue, chronic cough, chest tightness, cyanosis of the lips and nails, wheezing, shortness of breath, unintended weight loss, and peripheral edema. Here is an example of a COPD patient. They expend a significant amount of energy to breathe because airflow into the lungs becomes increasingly difficult. There are a few ways to treat COPD. 1. Stop smoking. Quitting smoking is the most effective way to slow COPD progression and improve lung function and overall health. 2. Bronchodilators. Bronchodilators relax airway muscles, improving airflow, reducing breathlessness, and enhancing daily activity tolerance in COPD patients. 3. Pulmonary rehabilitation. Pulmonary rehabilitation combines exercise, education, and support to improve lung function, physical endurance, and quality of life. 4. Vaccinations. Vaccinations, including influenza and pneumococcal vaccines, reduce the risk of respiratory infections that can worsen COPD symptoms. 5. Oxygen therapy. Oxygen therapy helps maintain adequate oxygen levels in COPD patients with hypoxemia, improving energy, organ function, and survival. 6. Medication for flare-ups. Short-term medications such as corticosteroids and antibiotics manage COPD exacerbations, reducing inflammation and infection severity during flare-ups. We talked to a respiratory therapist. Here's what we learned.
Hi, my name is Arlene. My group and I are doing project for COPD. Can you please introduce yourself?
Hi, my name is Jared Dansel. I'm a respiratory therapist for 5 years. I currently work at Sutter Solano Medical Facility, and I started my journey as a respiratory therapist in 2018 at Napa Valley College and graduated in 2020.
Can you give us details of what you have seen in the hospital dealing with COPD patients?
Sure, that's a great question. I've seen many patients dealing with COPD. It's a real bad disease, often can be preventable. But the main thing with COPD patients is either they get inflammation in the bronchioles as part of the disease, or they can lose the fibrin in their lungs, which loses the elasticity, which makes it hard for them to exhale, breathe out. And they just retain more CO2. And dealing with that when they first come in, if they have like a COPD exacerbation, and usually I'll judge whether if they just need like maybe a breathing treatment, usually with albuterol to help open them up, meaning like to help open the bronchioles, which albuterol does. If they have like a really bad COPD exacerbation, then we might have to put them on a machine which deals with NIPPV, which is non-invasive positive pressure ventilation. Usually the machine is called a V60, and this helps patients breathe out, and it helps with their work of breathing.
And how do you get a COPD?
So usually COPD can be caused by a couple of different ways. So first way, which is the most prevalent, is smoking. People who smoke many cigarettes for many years can get COPD. The second one is environmental factors like pollution, where they live. If they go where high smoke areas, fires or something like that, that's another way of getting COPD. And the other one is a rare gene defect, I believe, is the other way. That one is rare. Classic signs of COPD, usually they'll have sometimes they'll have a very violent cough. Sometimes they have a lot of mucus production. What happens is that they destroy their mucous membrane elevator. They destroy that, and so all their sputum collects into their lungs and they're not able to cough it up. You have violent coughs. Another classic sign of COPD is when they have elevated CO2. You can't see that until they become very lethargic. Lethargic meaning that it's hard for them to respond to your questions, or they can't really respond to you in general. And then when they become very somnolent meaning they don't respond to you at all. Another sign of COPD, sometimes they'll be very wheezy, though you hear a high-pitched sound if you put a stethoscope onto their lung or to their front of their chest or the back of the chest or their back, and you hear a high-pitched noise every time they breathe in. That's another sign of COPD.
What is a typical ABG for a patient with COPD?
So what an ABG is, first we'll describe what an ABG is. An ABG is an arterial blood gas. Usually we can, as a respiratory therapist, we can draw ABGs from the radial artery, brachial, or femoral. And so with a typical ABG for a patient with COPD, their pH would be normal, which is in the 7.35 to 7.45 range. Their CO2, because they can't ventilate that well, would be high. Their CO2 would be above 45. Sometimes it'll range from 50s all the way, I've seen it all the way up to the hundreds. With them, they'll have an elevated CO2, and then they'll also have a elevated bicarb to compensate for that. Usually their bicarb will be high in the high 20s to low 40s. That would make their pH compensated, meaning it'll be in the normal. So we call that compensated respiratory acidosis. And patients with really bad COPDs, they'll have a really bad elevated CO2 and they can't ventilate, so either because they're not taking their breathing treatments or their maintenance drugs, like inhalers or something like that. And so their CO2 will be very elevated, and enough for them to come to the hospital. We'll first assess them, maybe put them on a breathing treatment of albuterol. If they're really, really bad, we'll then put them on a non-invasive positive pressure ventilation machine, maybe a V60 in tandem with albuterol treatments to try to get them down. The nurse will probably give them a dose of corticosteroid just to help open up their lung. And then we'll do a repeat ABG to see if we can get that ABG back to normal. And if worse comes to worse, and if we can't reverse that high CO2, eventually what we do, we'll have to control the breathing for them. We'll have to intubate them. Intubate meaning putting an ET tube down their throat and into their trachea and then we'll hook that up to a ventilator, and then with that ventilator we'll control their breathing, either how much air goes into their lungs and then how fast it goes into the lungs, so that we can get that CO2 down. And once that comes down, we'll eventually take out the tube, extubate them, and try to get them on their way, and then try to prevent that from ever happening again. We'll do follow-up questions, see if they can, see if they're following their routine. Maybe they have to do breathing treatments every 4 hours or something at home, and then keep helping them take their maintenance drugs. And if they sometimes will have patients go home with a non-invasive positive pressure ventilation machine for home use when they sleep.
Arlene was so astonished and amazed that she forgot to thank the respiratory therapist. Thank you, Jared Densel. We were lucky enough to have a conversation with some COPD patients.
Can you tell me a little bit about when you were first diagnosed with COPD?
Oh, that was probably about 15 years ago.
Okay. And then what symptoms did you start noticing before you were diagnosed?
I just went to the doctors for a general checkup, and they checked my oxygen level, and they told me I had, he ordered some tests, and I went and did the tests, and he came back and he said, yeah, you have COPD.
What kind of medications did the doctor recommended to you or prescribe to you? And are you still taking the medications?
Yeah. SPIRIVA.
Do you feel like it makes you feel a bit better, breathe better?
Yeah, it takes about a half hour to kick in. It generally elevates my oxygen from 85 up to 90.
And what other things do you do to help you with your breathing?
Well, right now, oxygen concentrator.
Do you know what caused you getting COPD?
Smoking.
How many pack would you say you smoke a day, and for how many years?
I smoked generally about a pack a day. Right now, I smoke about 3 or 4 cigarettes a day.
Have you ever been hospitalized for COPD?
No.
And then has COPD changed your daily life routines, activities?
Oh, yeah. Yeah, I don't have the stamina like I used to. I used to work practically 16 hours a day. And now I can't do it even an hour.
Do you try to do anything to avoid breathing problems and stuff?
No.
Any thoughts of quitting smoking or?
I mean, I reduced my smoking quite a bit, but still not enough. I should stop it altogether.
So you would say that it's been getting worse in the last 2 years or so?
Last year.
Anything to cause that, to make it go worse, or just you think it's just age or something?
Well, age-related, yeah.
Who would you say that has supported you the most? Like your family or friends, healthcare teams? Have they really helped you with coping with COPD? Yeah, in the healthcare, do they provide you with education on what to do at home to minimize the
No.
And what about family? They try to help you out with it or try to tell you to stop smoking?
My wife smokes, so she's not going to tell me to stop.
And then what has been the hardest part of living with COPD?
Not being able to do the things that you want to do.
If you could go back, would you stop smoking 55 years ago?
Oh yeah, definitely. Just look at all the money I spent on smoking,
What advice would you give to someone who was just diagnosed with COPD?
If they smoke, stop smoking, Sometimes working in environmental conditions may be worse than smoking. You got to take care of your lungs. That's the bottom line,
Thank you so much for letting me interview you, Simon. See you.
All right, bye.
One of our interviewers had the opportunity to speak with a patient who has genetic COPD. For technical reasons, the questions will be shown in a written format. We apologize for any disruption caused by background noise. When and how were you diagnosed with COPD?
I was just about to turn 50, and I thought I had asthma because that's what they kept telling me I had. And so I got real shortness of breath, and I couldn't breathe, and I was screaming for my son to call 911. And he did, and they came and took me to Kaiser in Walnut Creek because we lived in the Bay Area at the time. So when I got to Walnut Creek, they x-rayed my lung, and I was in the hospital there for 4 days. They called it COPD exasperation. After that happened, they referred me to a pulmonary specialist. He diagnosed me with COPD and then also the alpha 1. I was actually admitted on my birthday or the day before my birthday.
How does your shortness of breath affect your daily activities?
A lot. I've gotten a lot worse since COVID, and I think that's kind of my fault too because COVID happened. Everybody that had COPD was dying from COVID, so I was scared to go outside pretty much. And I started working from home, not getting out for a few months after that happened. I don't really go anywhere except for on Mondays I go to Kaiser for my infusion.
How often do you get admitted to the hospital for your symptoms?
Every year around December or January, so it's coming up again. I've lost a bunch of weight, so I'm hoping that it's going to help me this time, maybe. I mean, I'm there every year for usually a week.
What does a typical bad day look like for someone with COPD?
A bad day is just when I can barely get around at all, and I have my oxygen on all day long.
Do you take your oxygen with you when you go outside?
You know, I used to, but not anymore. I kind of like maybe losing weight has helped a little bit. I don't take it out anymore, and then I have a walker in the back seat of my car. The walker just keeps me steady on my feet.
Are you in a pulmonary rehab program?
Not right now, but I've done that program I think 4 times.
Are you using inhalers? If so, how often?
I use inhalers every day. I have maintenance ones that I use every day, and then I have the albuterol that I use as needed. But it's always like within arm's reach of wherever I'm at. So if I need it, I can use it.
Thank you for sharing your stories. Join us in raising awareness for COPD. Share this video, encourage loved ones to quit smoking, and support local lung health programs today, such as SJVC Carrington College. Stay active and educate others about the risks of COPD. Help protect those around you, promote smoke-free environments, and advocate for better respiratory care in your community.